So our next speaker, Kay Redfield Jamison, is not only a professor of psychiatry at Johns Hopkins, which most of you will know is in Baltimore on the east coast of the US, but she's also a professor of English here in St Andrews, which I think is an extremely interesting combination. And she's the co-author of the standard medical textbook on bipolar illness, as well as the author of An Unquiet Mind, a book about our own struggle with bipolar illness.
Thank you. I'm delighted to be here. I'm going to be giving a very clinical talk and starting by talking a little bit about diagnosis of bipolar illness, primarily about treatment, but fortunately there is a correlation between diagnosis and the treatment that you're supposed to be using, so it's important to get the diagnosis right. So I'm going to be talking, first of all, about differentiating major depression from bipolar depression, because this is the critical clinical issue. And I want to go into that in a little bit of detail. Talk about treatment, suicide prevention, because this is a potentially very lethal illness. And then talk about I'm always telling residents and medical students, it doesn't do you any good to have drugs that are very effective if people don't take the drugs. And so I want to talk about, and the major problem in treating bipolar illness is not that we don't have good medications, we don't have perhaps ideal ones, but we certainly have good ones. But the major clinical problem in the illness is that people don't take the drugs. So just a very brief rundown on what we mean by mood disorders, and I just want to focus on one thing. By and large, mood disorders are divvied up into two major groups of bipolar disorders, where an individual has a history of depression and mania, or mild mania, and then just straight depression alone, unipolar depression. What I'd like to point out here, and this is the source of a great deal of diagnostic confusion, is recurrent depression, which is listed under depressive disorders, is in fact, if you look at people who have quite recurrent depression, their family histories, the natural course of the illness, their treatment response, and the nature of the clinical presentation of the depression is much more like bipolar depression than depression. And why does that make a difference? Well, there are a lot of obvious biological reasons and scientific reasons why it makes a difference, but it really makes a difference because you don't want to be treating, by and large, you don't want to be treating bipolar depression like you treat unipolar depression. So how do we differentiate it? What are the things we know? First, the most common diagnostic mistake in looking at across the board of mood disorders is to call something major depression or unipolar depression rather than bipolar depression, where there's only a history of very mild manic illness. And by mild manic illness, one of the problems that happens is that we tend to think of mania, we tend to think of a euphoric, high elevated state. But in fact, as common as not, 50% of people who have manias, they never get euphoric, they never get ecstatic, they don't get expansive, they get irritable, cantankerous, and paranoid. And those people do not present in the same ways. Most psychiatrists and psychologists looking at those patients very often miss that and misdiagnose it as unipolar depression. There are a lot of reasons for underdiagnosis of bipolarity, and I won't go into them in any great detail, but to say that first and foremost, people who are, when they're depressed, do not tend to remember ever being manic. You can have a patient in your office, and you can have a pile of charts like this for manic hospitalizations, and you can ask the patient, have you ever been manic? No. It's a very depression overwhelms, the mood of depression so overwhelms memory of any time that was actually felt slightly better than that. And very often the family's not consulted. And so a family member very often will say, oh, absolutely, the person was manic. Absolutely, the person was high as a kite, spending lots of money, up all night, irritable, and so forth. The patients themselves may not report that. What do we know about people who have bipolar illness in terms of early presentation? We know that bipolar illness is a very early onset illness. Depression is relatively early onset, but bipolar illness is really quite early onset, and it's certainly earlier than unipolar depression. It's a much more recurrent illness than unipolar depression. Postpartum episodes are far more frequent in women who have bipolar illness than unipolar illness, and rapid cycling almost by definition. This is just a slide to point out the early onset here of bipolar illness. Again, it's an illness of youth, and you can see that the preponderance of presentation, clinical presentation of bipolar illness is under the age of 30 and actually under the age of 25. Whereas unipolar illness is much more distributed into the 40s and so forth. Okay, so what do we know about depression and bipolar illness and just regular garden variety clinical depression? They share in common certain obvious features. One is depressed mood, not surprisingly. Cognitive difficulties, and this is, of all of the things that I think that are most emphasized about mood disorders, is the tremendous cognitive problems that people have. And it's very important in students, very important in anybody. I mean, oops, what did I do? Nope. And we call them mood disorders. We focus upon the aspects of irritability and depression. But in point of fact, you could as easily call these disorders of sleep, energy, and thinking. And it's important to keep that in mind. And cognitive difficulties are profound in both kinds of depression. Likewise, sleep disorder and problems in energy. But the differences, and I won't go into these in great detail, there are many clinical differences between bipolar depression and unipolar depression. There tends to be a lot more anxiety in unipolar depression and a lot more somatic components, hypochondriasis and so forth, and higher in bipolar illness are very agitated and perturbed states, a lot of mood lability. Substance abuse is considerably more common. And this is like the earlier slide about in terms of complexity. We tend not to focus on, there can be other causes of mania. We tend to focus on the fact that we all know that there are medical conditions that can look like depression. I mean, from thyroid conditions to various metabolic conditions and so forth. But it's also important to realize that there are a lot of things that can look like mania and hypomania. And nobody in his right mind would ever think of all these things for obvious reasons. But it's just important to keep that in mind. It's also important that we tend to focus upon the mortality associated with depression for good cause, because it's much more common than mania. But it's very important to realize that prior to the antipsychotic medications, a not infrequent cause of death in mania was manic exhaustion. People died of mania. And this is a study actually out of Dr. Kay's hospital in Australia, who's the person who's actually responsible for lithium being out and about in the clinical world. And what he showed very clearly was that in his hospital, just the number of deaths from mania before, when the phenothiazines first Thorazine came out, and you can see this sharp decrease. In this day and age, someone who is ravingly manic, by and large, is going to come to the attention of the police or be admitted involuntarily. So let me just get to treatment. Again, it's important to get the diagnosis right. I perseverate here, but there's nothing worse than treating somebody for depression when they have bipolar illness. The courses of the illness are quite different, and although both forms are lethal, you can probably make somebody quite suicidal by precipitating a mixed state or an agitated state with antidepressants in somebody who has bipolar 1, where you don't run the same kind of risk if they have depression alone. So I'm not going to go into details of depression, treatments for depression, because I'm going to be focusing on bipolar illness. But I do want to say one thing about the antidepressants. I mean, and I can't begin to go into the counter arguments to say reasons why the antidepressants are actually more efficacious than you would believe reading the press these days, including the medical press, which I think has been outrageous to some extent. That one of the reasons why antidepressants probably work better than their current reputation is what people have been doing is giving antidepressants to milder and milder cases of depression for all sorts of reasons, some of them less than admirable. But so they've extended that spectrum of severity. And what that means is that antidepressants tend to work actually quite well in severe and moderate forms of depression. They work less well in people who have mild depression. So if you start excluding people, which is what is routinely done in drug trials, if anybody has a history of a suicide attempt, they're excluded. Now, if you ran this by people in cardiovascular research or people in oncology and you said, oh, we're just going to take out all the people who might die from their cancers or heart disease and we're not going to treat them because there might be in the case of antidepressants, there might be a suicide and then the drug companies are liable. So, it's been skewed very much toward treating people who have relatively mild forms of the illness. But in fact, what we know from the earlier literature is that they work better with more severe forms. So we have a slew of antidepressants, psychotherapy combined, and we know from quite a bit of literature that in many cases the combined use of psychotherapy and medications is better than either one alone. And this turns out to be the case for bipolar illness as well. So what you want to do in any case, if you are going to put somebody who has a bipolar form of depression on antidepressants, doesn't necessarily mean they shouldn't be on antidepressants. It means that they should generally be covered by a mood-stabilizing drug like lithium or the anticonvulsants. But it also means that you want to monitor them very carefully. And I think that one of the best things that came out of the FDA putting a major warning on the use of antidepressants is that now doctors are much more liable to have to actually monitor patients because there is a subgroup of patients that is going to get more agitated, more perturbed, and more potentially suicidal or violent. So you want always, in any case, you want to be informing patients and their family members up front, orally, in writing, what the risk might be of the treatment, and to the phone numbers and so forth, how to contact it. I mean, very often just predicting that there might be agitation can help people to deal with it. Okay, so the primary treatments for bipolar disorder, the standard, and I will get back to this in a minute, and it gets a little bit into the progesterone story, which is to have a neuroprotective drug that has no patent protection makes current research a little bit difficult. The gold standard for research for treatment of bipolar illness remains, on the basis of the scientific and clinical literature, very clearly lithium. However, there is absolutely no profit margin in lithium because it's not patentable. And as a result, and not everybody can take it. A lot of people have very bad reactions to it, as they do to almost most of these drugs. And so what happened was that anticonvulsant medications started being used. They worked in a certain number of people. They worked quite well in some people, not so well in others. And so, in fact, if you look in the United States and increasingly in Europe, the prescriptions for lithium have gone way down like this. And the prescriptions for the anticonvulsants have just gone up like this. And the guidelines for the drugs, until recently, because a lot of us protested, were very pro-anticonvulsant medication, even though the science was really much more clearly on the side of lithium. There are also a lot of antipsychotic medications, and many people would argue overused in the case of bipolar illness. Antidepressants, ECT, the electroshock treatment, remains a very good and effective treatment for very severe depressions, bipolar depressions, which do carry a substantial suicide risk. And interestingly, it also is very effective in acute mania. So there's some instances still where, for some reasons, somebody has to be treated for acute mania. They can't be treated with anything else. ECT often works quite well. And then I want to get into psychotherapy, adjunctive psychotherapy, in a minute, after talking about why people don't take their medication. First, I want to diverge a bit into suicide, because one of the things that's most frustrating, I think, for people who treat schizophrenia, bipolar illness, severe depression, is that in psychiatry we don't talk about mortality rates. We just don't. There are minimally a million suicides a year across the world, tendency to underreport suicide. And we don't, it's not like talking about death rates from cancers or heart disease. We don't talk about death rates. We should, because these are not only deaths, these are young deaths. People die young, and somebody's just as dead of suicide as they are of Hopkins disease. So our first obligation of a clinician who treats severe mood disorders is first and foremost to keep people alive. This doesn't tend to get the attention it should. This is just a quote from Professor Emil Kraepelin, who's the major writer on manic depressive illness. He said, the patients therefore often try to starve themselves, to hang themselves, to cut their arteries. They beg that they may be driven out into the woods and they're allowed to die. One of my patients stuck his neck so often on the edge of a chisel fixed on the ground that all of the soft parts were cut through to the vertebrae. And I bring this up for a couple reasons. One is it's a really desperate state. People kill themselves out of a great deal of pain and agitation, and it's often a very violent way to die. Suicide is, we talk about, and again, in psychiatry and psychology, for some reason best known to the gods, we tend to talk about it as a rare event. It's not a rare event. It's not a rare cause of death. And you can see, actually, if you look at causes of death in adults aged 15 to 59, that in fact, suicide is right up there near the top of deaths. And one really important thing clinically and humanistically about suicide in bipolar patients, depressed patients, and patients with schizophrenia is that the suicides tend to occur early on in the illness. And why does it make a difference? It makes a difference because this is when people are least likely to be diagnosed properly, least likely to have accepted their illness, and least likely to be adherent to their medicines. So you have everything going against you clinically to save someone's life. And what does that mean? It means you really want to intensify, I think anyway, you really want to intensify psychotherapeutic efforts very much early on in the illness, where they can make not just a difference in terms of the quality of life, but whether or not somebody actually stays alive. So this is a study that came out of Sweden, about 15,000 patients who'd been hospitalized for bipolar disorder, and what you can see is that across all age groups, there's a very much elevated rate of suicide compared with the general population rate, but absolutely staggeringly high under the age of 30. You've got women being 72 times more likely to kill themselves, and men about 82 times more likely to kill themselves. And in fact, bipolar illness is the only illness in which women and men kill themselves equally often. Generally, the rate of suicide is much higher in men than it is in women, but in bipolar illness, it's equally common. So what are the risk factors for people who have bipolar illness to kill themselves? Severe depression with agitation in particular, people who are just pacing back and forth like tigers are describing this enormous pent-up energy, distressing energy, perturbance, a lot of rapid cycling of moods, and very impulsive behaviors. And I just want to get back in a couple slides here to the issue of lithium. Why do quite a few of us really particularly strongly advocate for lithium? One is because it works better clinically in terms of preventing manias and depressions. But it also seems to have a genuinely protective effect against suicide. And this has been shown in about 35 studies now that suicide rates go down in people who are on lithium. So this is a really important thing, again, in terms of saving lives. This is a study done at Harvard by Ross Baldessarini, who's done quite a few studies looking at this one way or another. And this is just showing that I think this is one of those public health phenomena where you have a drug come in that is advertised as being newer, better, fewer side effects, And lithium has this kind of old toxic quality to it, And the question is, it's a public health issue of how much you are able to convince the public, the medical public, that something works better than something when it really doesn't. So this is one of the several studies showing that, in fact, a recent study showing that lithium works better than anticonvulsants. And just 2 slides here, and I'm focusing on physicians mainly because I generally teach physicians and medical students and graduate students. This is also true for women graduate students and women PhDs. A very much elevated rate of suicide in physicians, particularly women physicians. And why is this important? It's important because it's a terrible loss, obviously, for anyone when they die by suicide. But it also means that we're not doing something right in terms of dealing with the issues of stigma and encouraging people to get into care for treatable disorders. Depression is really treatable. And one of the things that we tell our medical students every year at Hopkins is, look, a lot of you are going to get depressed. That's life. That's just the way it is. It's a really common illness. We're not going to hold you accountable for that. You're not responsible for that. But you are responsible for getting treated. We can't have untreated doctors. And you're responsible for keeping a wing out for your colleagues, making sure that they get into treatment if they need it. So these are treatable disorders. You don't want people dying unnecessarily. And there are quite a few risk factors in physicians that first of all, they're more likely to have affective disorders, mood disorders, than the general public. But they also have access to lethal means. And this is particularly true for women who tend to know the medications, know the lethality in a way in which many women out in the general public don't know the lethalities of the drugs that may or may not kill them. There are also access to a lot of stress and sleep deprivation, which are concerning. So let me just end on medication adherence. I'll just take the liberty of quoting myself. One of the reasons I wrote about my own bipolar illness, which I wasn't really wild about doing for a lot of very obvious reasons, was that the first years of my life with my illness after I was diagnosed, I would take my medication, I would get all well, and then I'd stop it. This is a very standard pattern. I didn't want other people to go through what I went through. I nearly died on several occasions, and it's a horrible way to go through life. So the endless questioning finally ended. My psychiatrist looked at me. There was no uncertainty in his voice. Manic depressive illness. I admired his bluntness. I wished him locusts on his lands and a pox upon his house. Silent, unbelievable rage. I smiled pleasantly. He smiled back. The war had just begun. And I think for anyone who's been in this situation, if you look at the literature, actually, about 50% of people, if they're prescribed medication, they take it. This is a group of people I always find interesting, not an intuitively obvious group of people. And then the other 50% struggle to one extent or another with the sentence they feel they've been dealt, with denial, with once they get well, thinking, it's not going to happen to me again, I'm not going to eat red dyes, I'm going to exercise more, I'm not going to break up in a relationship, I'm not going to, all the things that people go through to deny that they've got an illness that needs looking after. So the major clinical problem, again, in treating bipolar illness is not that we lack effective medications. It's that we lack patients who take those medications. So we know that about 45 to 50% of bipolar patients do not take their medications as prescribed. And we also know that this is not that unusual in the rest of medicine or in the rest of psychiatric medications, that non-compliance rates are high in any kind of chronic illness. It's an overall problem. It's not a very intellectually sexy sort of problem in medicine, so it doesn't get very much attention. There's kind of a long series of somewhat dreary studies, but for the most part, it's not really looked at, and it's terribly important in keeping people alive. I'd like to point out something else. It is not just chronic diseases that have problems. I live in Washington, and after 9/11, within a period of about a month or so, we had a sniper, in addition to being bombed, the city being bombed, we also had a sniper who took out about 10 or 12 people, terrorized the city, absolute terrorists, just show up randomly, shoot people, and kill them. And then we had anthrax scare. So it was a great time to be living in Washington. And one of the things that was very interesting about the anthrax scare was that, in fact, if you think about it, there's absolutely no stigma attached to being on the end of being exposed to anthrax, right? I mean, nobody holds you accountable or whatever in the same way that they do if you have a psychiatric illness. Everybody that was exposed to the anthrax got free medication. So there were none. Psychiatric drugs cost a boatload of money, and over long periods of time in the States. They don't here, obviously, but they do in the States. This was a 3-week supply given absolutely free by the government of Cipro. And under those circumstances, where people thought that there was a possibility they could die, they only had to take medication for 3 weeks. A lot of people just didn't take their medication, right? So there's something intrinsic to the human condition that says, maybe, maybe not, or I get a side effect from the Cipro, forget it. It's too much effort to fill a prescription, whatever it is. It's just not obvious that people are going to take medications, even under circumstances where it's really short term. And they're, kind of a classic study of physicians where people had upper respiratory infections, and everybody knew that they would, they had to take their medications, and people didn't take their medications. Half of them didn't take their medications for a short period of time, over a short period of time. With psychiatric illnesses, you've got it for a lifetime. If you're 18 years old and somebody tells you you've got bipolar illness, or in my case, before they call it bipolar, it was manic depressive illness, you've got it. It's not going anywhere. So you've got to make all sorts of arrangements with your head and with your notions of who you are and where you've been and where you're going to try and figure that one out. It's difficult. Antidepressant, looking at post-mortem studies of people who've been diagnosed and put on antidepressants, again, very few people were actually taking their antidepressants at the time they killed themselves. And even though those that were taking their antidepressants at the time they killed themselves, most of them were taking clinically ineffective. They may as well not have been taking it because they weren't at an adequate dose. Yeah. Okay, so what do we know about the correlates of non-adherence? One is that if you have, as I explained earlier, maybe 50% of people who get bipolar illness get these euphoric, expansive highs, and 50% don't. The people who have a history of these expansive euphoric highs are the most likely to respond to lithium and the least likely to take lithium. So it's one of those little ironies of medicine, that people who get these positive states, as you might imagine, find it difficult to give them up. And in fact, you can really think of these manic states, these euphoric states, as in many ways addictive to yourself. You're addicted to your own brain. And when you think about what people will do for cocaine addiction, if they've got a cocaine habit, they will go through their money, they will go through their families, they will go through everything, they will ruin everything, essentially, that means anything to them in life. Now, mania leaves cocaine in the dust, okay? There's just, in terms of the incredible euphoria and energy. I mean, cocaine is a very short-acting drug. It's not nearly as intense a drug, and you've got to go out and buy it. In the case of mania, it's not that mania doesn't cost you money, because it does in other ways, but it's the mania, really just comes from within. And so a lot of people with bipolar illness spend a lot of their time trying to go back and recapture these high states, and to their detriment. So that's a real correlate of noncompliance, is people who get the euphoric highs. Living alone. Side effects, as you might imagine, real distribution and severity of side effects. Denial, substance abuse is a real correlate, and sometimes personality disorders, so that's less clear. So I just wanted to end on saying, what can you do about this if you have medications that work, if you have anticonvulsant medications or antidepressants or lithium or some combination of these medications, how can you encourage people to take them? And it turns out actually psychotherapy has a real impact on this in the sense of there's a series of studies. Almost all of these studies, I should say, are cognitive behavior therapy studies. Doesn't mean that cognitive behavior therapy is the only therapy that works. It just means that cognitive behavior therapy tends to get grants. I mean, because it's manualized, it's very systematic. It doesn't mean that the therapies doesn't work. It just means that that's what's been studied. And so I think it's very important. There was a tendency when I first, I ran the mood disorders clinic at UCLA for many years, and it was in a time where psychoanalysis was really pretty dominant and as a form of treatment, and was just kind of going out as medications were coming in. And there was a tendency there, everybody who was into psychopharmacology was just enraged with the psychotherapeutic world because they thought people had been sold a bill of goods, didn't work, and there was good cause for that. I mean, people were dying, they were getting worse. There was no evidence that psychotherapy alone treated anything for anybody with serious mood disorder. But what happened then was people just sort of really dismissed psychotherapy as an effective treatment. And what's, I think, happened over the last 10 or 15 years, which has been quite wonderful, is to see that psychotherapy has really come back in. People have studied it, people have looked at it, and said, no, this keeps people alive. If it's not just making people feel better, it's really keeping people on their medications, particularly during a very difficult time of people in their 20s and early 30s. So I just would end with Hippocrates, that the physician must be ready not only to do his duty himself, but also to secure the cooperation of the patient. And this is one of the things that, certainly at Hopkins, one of the things we really try to tell young doctors is it just isn't enough to prescribe something. You have got to make a persuasive case based on science and based on our understanding of the illness and the consequences of the illness. You have to be able to persuade people to make choices for themselves. Thank you.
Okay, we've got time for just one or two questions before we have a break. Can I ask you, why do you think these disorders are commoner in doctors?
I think there's a certain, and I'd be curious to know. I mean, these are relatively old data, and this is 20 years old, 30 years old, and it may be changing, but first of all, selection factors, that people who have been through a certain amount of depression or suffering, perhaps are unduly drawn to the healing arts. I think there is an element of that. Also, what happens is, I think what we see at Hopkins, for example, and we certainly saw at UCLA, was that students may come in with a history of depression, okay, and nobody knows that, and they've sort of treated themselves, they've ignored it, or they've gone to a private doctor or something, they've done okay. But then as life goes by, the tendency is for the illness to get worse over time. And so they may make it okay in the first couple of years of medical school, which is basic science, and then they get in the third year and they go on clinical rotations, and they stay up all night. Now, the single easiest way to get somebody manic who has bipolar illness is to deprive them of a night's sleep. So what happens is there's this acute stressor, biological stressor, and that's when we end up seeing medical students, is in their third year. It's because it's an illness that's distributed, into the 20s and 30s, you can certainly get by. Now, I say it may change. I mean, I sit on the admissions committee at Hopkins for the medical school, and one of the things that's very clear to me is that, these people don't have time to get depressed. I mean, these people are all out volunteering. They're working in some Nobel laureate's lab. They've got 4.0 grade points. They've got MCATs off the charts. I mean, it's very hard. They're very homogenous group, and I think they're more homogenized now. And I hope very much that doesn't weed out people who have a diversity. People babble on these committees about diversity of gender, diversity of race, religion, background, and so forth. They don't talk about diversity of brains, and illnesses. And I think that's a very real issue, actually. But that's, of course, I'm prejudiced.
Any other question anybody wants to ask?
Do they ever take, whether it's males or females, but especially females, does anybody ever look at a hormonal panel to see what their hormonal regulation is? Because a lot of the treatments you talked about upregulate or affect GABA.
Right.
And, these are important factors, especially pituitary hypothalamic. Do that routinely?
No, they don't. They do not do it routinely. Is it studied? Yes. I mean, there are quite a few clinics and research projects specifically on women, for example, with mood disorders and looking at various things. Interestingly enough, if you look back 80 years or so, there was the use of estrogen for psychosis. And so I think that people are looking at those things, and perhaps not as much as they should. But one of the things that's interesting, of course, as you said, I think that the neuroprotective aspect is a very compelling argument. In the case of lithium, there's very strong evidence that it's neuroprotective and it actually regenerates some of the loss. So. Yeah.
Okay, right, we're going to take a break for half an hour, so be sure to be back on time at 3:20, and let's thank Kay again.